Hi, this is Ben. Let's talk about nephron physiology briefly. We will begin by focusing on the first part of the nephron called the proximal convoluted tubule, highlighted by the red box in this slide. It is located just downstream of Bowman's capsule and is where most filtered solutes, electrolytes, and water are reabsorbed back into the bloodstream. In fact, 60 to 80% of the filtered sodium is reabsorbed in just this one small segment. Do you know what two specific molecules are almost completely reabsorbed here? That's right, glucose and amino acids. Proximal convoluted tubule is also the only portion of the nephron to contain a brush border similar to the one seen in the small intestine. Its purpose here is to increase the surface area and absorptive capacity of this part of the nephron. Moving to a magnified view of the PCT, we can see the cells of the proximal convoluted tubule and their uneven brush border. At the top of the image is the tubular lumen where filtrate flows, and at the bottom of the image is a paratubular capillary where blood flows. Do you remember where these paratubular capillaries originate from? Correct, the efferent arteriole. As mentioned before, the PCT is responsible for reabsorbing glucose and amino acids that are filtered into the tubular lumen. This is done with the help of sodium-dependent cotransporters. Negatively charged phosphates and organic molecules like lactate and citrate are also absorbed in a similar manner. These sodium cotransporters are all powered by a basolateral sodium-potassium ATPase that generates a favorable sodium gradient. After glucose, amino acids, and phosphate have all moved into the tubular cells, they can be transferred to the blood by the presence of basolateral transporters. One important note about this part of the nephron is that parathyroid hormone acts here to inhibit the reabsorption of phosphate. An inhibitory cyclic AMP signal acts on the phosphate transporter, causing phosphate to be lost in the urine. Another important function of the PCT is to absorb filtered bicarb that would otherwise be lost in the urine. The problem, though, is that bicarb does not have a designated transporter like we have seen previously. For bicarb to be reabsorbed, it must first be turned into CO2, which is a small, nonpolar molecule that can easily pass into tubular cells by simple diffusion. Filtered bicarbonate combines with a hydrogen ion that is pumped into the tubular lumen by a sodium H+ antiporter. Then it forms carbonic acid. This reaction is catalyzed by what enzyme? Correct, carbonic anhydrase. Carbonic acid can then undergo a spontaneous reaction to form CO2 and water. Nonpolar CO2 is then able to freely diffuse into the tubular cell and can be converted back to bicarb within the cell by running all these reactions in reverse. HCO3- or bicarb is then transferred to the bloodstream by a specific transporter. I know that all this can seem a bit complicated, but if you just remember the overall picture, you will be well prepared for your exams. Now, just for a few additional points. The first is that the sodium-hydrogen exchange is stimulated by angiotensin II. What would this stimulation lead to? Increased sodium and water reabsorption followed by an increase in blood pressure is one primary effect. Angiotensin II will also stimulate the reabsorption of bicarb, as we just saw, and increase the pH of blood in a process known as contraction alkalosis. The second point is that the enzyme carbonic anhydrase can be inhibited by a specific class of drugs. These drugs will inhibit the reabsorption of bicarb in addition to causing a mild diuresis of sodium and water. Can you name one specific carbonic anhydrase inhibitor? Correct, acetazolamide. And what condition is this drug classically used for? Acute mountain sickness, or its more severe forms, high-altitude pulmonary or high-altitude cerebral edema. Now we have talked about solute absorption, but we have not talked about water absorption. How is water reabsorbed in this part of the nephron? Well, the answer is isotonically, meaning with no associated change in osmolality. Water here passively follows the reabsorbed solutes by moving between cells in a paracellular fashion. And for the sake of completeness, I briefly wanted to point out a chloride formate transporter that corresponds to what is seen in your first aid text. The function of this antiporter is to help reabsorb chloride in the PCT. Alright, now let's move to the next part of the nephron. In the thin descending loop of Henle, sodium is trapped in the tubular lumen while water is passively reabsorbed from the urine filtrate. Do you remember what drives this water reabsorption? It is the hypertonicity of the surrounding medulla which allows for the concentration of the filtrate in this portion of the nephron. The thick ascending limb, in contrast, allows for solute reabsorption, but is impermeable to water. In fact, 10 to 20% of the filtered sodium is absorbed just in this one region. Why is the impermeability of the thick ascending limb so important? This makes the filtrate less concentrated and helps to generate the hypertonicity of the surrounding medulla. The medulla's hypertonicity allows water to be passively reabsorbed both in the descending loop of Henle and the collecting ducts as filtrate progresses through the nephron. Once again, with the tubular lumen on top and the peritubular capillary at the bottom, we can analyze what happens here on a cellular level in the thick ascending limb. The most important transporter in this region of the nephron is the NKCC cotransporter, which reabsorbs sodium, potassium, and chloride ions in a 1:1:2 ratio. The NKCC transporter is powered by a basolateral sodium-potassium ATPase that is responsible for generating a favorable sodium gradient. At the opposite side of the cell, both the potassium and chloride will proceed to diffuse down their electrochemical gradients through a series of ion-specific channels. In addition to the ions mentioned, the thick ascending limb is also responsible for reabsorbing magnesium and calcium. To facilitate the absorption of magnesium and calcium, there is a potassium channel located on the luminal surface that causes a backleak of potassium. Now this seems counterproductive because we just absorbed potassium with the NKCC transporter, but watch what happens next. As potassium diffuses back into the tubular lumen, it generates a positive charge that drives the pericellular movement of calcium and magnesium. Calcium absorption is especially important when you're discussing the use of diuretics. Do you know what drugs inhibit the NKCC transporter? That's correct, the loop diuretics. Any idea what these diuretics do to the renal excretion of calcium? They increase it by interfering with the pericellular transport we just mentioned. Overall, loop diuretics cause a substantial diuresis, which is often very necessary in certain edematous states, such as CHF, cirrhosis, nephrotic syndrome, and pulmonary edema. In a patient with recurrent kidney stones, why might you not want to use loop diuretics to treat their hypertension? That's because this will saturate the urine filtrate with calcium and predispose them to the formation of more kidney stones. Remember, the most common type of kidney stones are made of calcium oxalate. Do you know what other antihypertensive agent is a great choice for this type of patient? Correct, hydrochlorothiazide, because this type of diuretic will promote calcium reabsorption and help prevent renal stone formation. Now, before we move on, we should again revisit to what happens to water in this part of the nephron. Remember in the thick ascending loop of Henle, tubular cells are impermeable to water, which means that this segment of the nephron dilutes the filtrate, making it more hypotonic. Now let's move on to the next portion of the nephron. Now let's talk about the distal convoluted tubule, highlighted by the red box in this slide. In this portion of the nephron, 5 to 10% of the originally filtered sodium is reabsorbed in this segment. This is also the segment of the nephron where parathyroid hormone acts to increase the uptake of filtered calcium. In the early distal convoluted tubule, both sodium and chloride are absorbed into tubular cells by a cotransporter simply abbreviated as NCC. Chloride will then leave the tubular cell through a basolateral chloride channel and enter the blood. The excess sodium that builds up in the cell will participate in an exchange with potassium via the sodium-potassium ATPase, also on the basolateral membrane, and enter the bloodstream. The sodium-potassium ATPase is found in every part of the nephron as we have seen, and through the expenditure of ATP, sets up again a favorable sodium gradient. In this portion of the nephron, calcium is also reabsorbed into tubular cells by a calcium channel near the tubular lumen. This contrasts with the pericellular movement of calcium that is seen in the thick ascending loop of Henle. As mentioned previously, parathyroid hormone acts on the distal convoluted tubule to increase the reabsorption of filtered calcium, and it does so through the production of a second messenger, cyclic AMP. The excess calcium that builds up in the cell will then enter the bloodstream after exchange with sodium through a basolateral antiporter. This area of the nephron is also impermeable to water, just like the thick ascending loop of Henle, meaning that solute is absorbed but water is left behind. What will this do to the tonicity of the filtrate? It will dilute the filtrate and decrease its tonicity, which is why this area is sometimes called the cortical diluting segment. The net result is reabsorption of sodium, chloride, and calcium in the absence of water. Now, do you happen to know what drug inhibits the NCC transporter? That's right, thiazide diuretics, like hydrochlorothiazide. Before we move on, there's one key additional point that we should hammer home. It is that thiazide diuretics decrease the excretion of calcium in the urine. Don't worry, we'll work through this step by step. As thiazide diuretics block the NCC transporter, the intracellular concentration of sodium decreases. This decrease in sodium makes it more favorable for sodium to be exchanged for calcium at the basolateral membrane, which in turn causes calcium to enter the blood. As calcium leaves the intracellular space in exchange for sodium, calcium will be drawn from the tubular lumen, causing an overall decrease in calcium that is excreted in the urine. The last segment of the nephron is the collecting tubule, which is responsible for making final adjustments to the filtrate before it becomes urine that is stored in the bladder. In this portion of the nephron, only 2 to 5% of the filtered sodium is reabsorbed back into the bloodstream. This is also where ADH and aldosterone exert their effects in response to the hydration status and blood pressure of an individual. At the microscopic level, the collecting tubule is made up of two primary cell types, principal cells and alpha intercalated cells. The principal cell is responsible for reabsorption of sodium and secretion of potassium by specific ion channels located at its luminal surface. The sodium channel's official name is the ENaC channel, which is going to come up a few times, so it's worth mentioning here. The exchange of sodium and potassium does not occur in isolation, but is driven by the activity of the basolateral sodium-potassium ATPase. Aldosterone upregulates this process of sodium reabsorption and potassium excretion by its effects on an intracellular mineralocorticoid receptor. Through effects mediated by mRNA production and protein synthesis, the number of sodium channels and basolateral ATPases are increased. Blood pressure will then increase as a result of water following the flow of sodium and increasing the intravascular volume. Alpha intercalated cells work a bit differently and secrete hydrogen ions into the tubular lumen to decrease the pH of the urine, a process that is also upregulated by aldosterone. This is accomplished by a potassium-hydrogen exchanger and a special hydrogen pump. These hydrogen ions must come from somewhere and are derived from the action of carbonic anhydrase to produce bicarb and hydrogen ions within the cell. Excess bicarb is taken up into the bloodstream by a chloride bicarb exchanger. Aldosterone will also increase this process because it will supply the alpha intercalated cell with more potassium at its luminal surface. That can be exchanged for a hydrogen ion. What do you think would happen if there was too much aldosterone being secreted? Well, the patient will be retaining all that salt and water and losing their potassium stores. They would present with hypertension and hypokalemia. And what metabolic derangement would they have? Metabolic alkalosis, because they're losing a bunch of hydrogen ions too. Do you know what this syndrome is called? This is called primary hyperaldosteronism, or Conn syndrome. Also, for an additional note, this part of the nephron is the site of action of the K+ sparing diuretics. Can you name any off the top of your head? Great, tramtrine and amiloride. These drugs block the luminal ENaC sodium channel and promote sodium loss while preventing potassium loss. Before we move on to the collecting tubule, there's one more hormone that we need to talk about, and this is the ADH, or antidiuretic hormone. It binds to the principal cell through a basolateral receptor. Do you know what receptor this is? That's the V2 receptor. In response to ADH, aquaporins get inserted into the membrane through a cyclic AMP-mediated mechanism. Once at the membrane surface, the aquaporin channels allow water to be reabsorbed, thereby concentrating the urine. This physiology is important, so as you move forward with your studying, look back on this section in your book to refresh your memory about the function of the nephron. It's really important to know for the exam and will make you shine in your clinical rotations too. Flash quiz. What is the class of medication that both decreases sodium reabsorption in the nephron and inhibits aldosterone secretion? That's correct. ACE inhibitors. With the prevention of angiotensin II production, more sodium will be lost in the urine, leading to more water diuresis as well. Secondarily, without angiotensin II, there is no stimulus for aldosterone release, leading to increase in sodium and water loss and a decrease in blood pressure.